Okay, folks, welcome to week 4. And in week 4, we are going to be going through endocrinology with a specific focus on the pituitary gland. The pituitary gland is considered to be the master gland of all the endocrine hormones, but not all endocrine hormones are under the control of the pituitary gland. Today, we're going to focus on hormones which are controlled by the pituitary. Here are your readings from the textbook, and let's move on. So the pituitary gland, first thing, let's find the pituitary gland. So do you see the pituitary gland? We have a sagittal cadaver section here exposing the brain, and then we have an MRI, that same sagittal section of an MRI showing you the brain. Do you see the pituitary gland here? Pituitary gland is at the base of the brain, just underneath the back of the frontal lobe. It lives inside a cavity of bone referred to as the cella, S-E-L-L-A, and right above the cella is a sinus called the sphenoid sinus. Does that help you out find the pituitary gland here? Let's go to the next slide. And the blue arrows show you the pituitary gland. Again, sitting in the cella, which is a cavity at the base of the skull and right above the sphenoid sinus. The pituitary is attached back to the brain by a little stalk called the hypothalamus. So we'll be talking about the interactions of the hypothalamus with the pituitary gland. You can get close to your pituitary gland. What do I mean? So if you took your index finger, open up your mouth, take your index finger, touch the inside of your mouth at the hard palate and try to touch behind your nose. That makes sense. So you're trying to point inside your mouth behind your nose. You get to the hard palate and you're within a couple of centimeters of the pituitary gland. And that approach through the mouth, through the palate, or even approach through the nose itself is a surgical approach that you'll see done by neurosurgeons who operate on the pituitary gland, such as an individual with a pituitary gland tumor, something that we will be talking a fair amount about as we go through this unit. So the pituitary gland itself, here you see it shown in the cartoon, the pituitary gland is attached to the hypothalamus. The pituitary gland itself is divided into two parts, an anterior part and a posterior part. So we have an anterior pituitary and a posterior pituitary. Just a little bit on the posterior pituitary. There are two primary hormones that come out of the posterior pituitary gland, oxytocin, which has its effect on uterus and mammary glands. Oxytocin stimulates labor and uterine contractions. Oxytocin stimulates ejection of milk out of the mammary glands during breastfeeding. The other hormone is antidiuretic hormone, ADH, and it acts on the kidney to enhance water absorption. We're going to leave those two hormones alone as we are primarily going to focus on the anterior pituitary gland. Now, if you look at the anterior pituitary gland, it looks bigger than the posterior, and we see what's called a capillary portal, which is connecting the hypothalamus with the anterior pituitary. The hypothalamus is able to release a hormone into that capillary portal, which then travels to the anterior pituitary gland and then stimulates the pituitary gland to release a hormone that can then go into systemic circulation so that arterial venous capillary portal that you see between the hypothalamus and the anterior pituitary is an extremely important anatomic structure, and that's what allows the hypothalamus to have interactions directly with the anterior pituitary. Now, with respect to the hypothalamus and the pituitary gland, there is something called the hypothalamic pituitary axis. And this axis is a series of hormones which are released to stimulate organs within the body. And we're going to talk about this axis in some detail as we move on through this unit. The hypothalamus secretes a releasing hormone that goes through that capillary portal to the anterior pituitary gland, stimulating the anterior pituitary gland to release a stimulating hormone. That stimulating hormone then goes into systemic circulation and finds an end organ hormone, and then that end finds an end organ, and then the end organ releases an end organ hormone that goes back to have the physiologic functions on the body. That's referred to as the hypothalamic pituitary axis. Now, the end organ hormone, that final hormone in the series of three, is able to shut off its own stimulus and release by feeding back. So in this instance here, we're looking at the hypothalamic pituitary axis for the adrenal gland. And one of the primary hormones coming out of the adrenal gland is cortisol. So that's considered the end organ hormone. Cortisol, to limit its own synthesis and release, can feed back to either the pituitary or the hypothalamus and put a brake on that hormone. So cortisol can feed back to the anterior pituitary gland and put a release or put a brake on ACTH, or can feed back to the hypothalamus and put a brake on CRH. That's called negative feedback inhibition. The feedback to the anterior pituitary gland is called a short loop. The feedback to the hypothalamus is referred to as a long loop. So all these different hormones that are coming out of the anterior pituitary gland have this type of axis, which has both a stimulatory release and a negative feedback inhibition. We'll talk more about these more specifically as we get to each of the different hormones. There are a number of different hormones that come out of the anterior pituitary gland. So again, remember, the hypothalamus stimulates the anterior pituitary stimulates the end organ, and then the end organ releases the hormone that goes into systemic circulation and has a variety of physiologic effects on the body. The three that we are going to talk about today are growth hormone, thyroid hormone, and cortisol. The prolactin hormone and the reproductive hormones, FSH, LH, and their effects on androgens and estrogens, we're going to leave that alone in this unit. We're going to focus, like I said, on growth hormone, thyroid, and cortisol. Each of those three has its own specific and unique hypothalamic pituitary axis. So if you look at cells of the hypothalamus and if you look at cells of the pituitary, cells only are capable of releasing one type of hormone. One pituitary cell, one hypothalamic cell does not release them all. They just do their specific job. So you're going to have cells which are responsible for growth hormone, other cells responsible for thyroid stimulating hormone, etc., with the rest of them. Does that make sense? Again, just think of it. There's a specific axis, and within the axis are specific cells, and those cells are only releasing one type of hormone. Okay, I'm going to define this term really early on, an adenoma. An adenoma is a tumor. It's a benign tumor, meaning it's not cancer, it's not malignant. And it is a tumor of glandular tissue. Remember, glands secrete substances. Most glandular tissues are epithelial by origin, so adenomas are tumors of epithelial cells which are able to secrete some type of product. And sometimes what these adenomas secrete are hormones. So a pituitary adenoma is a glandular tumor of the pituitary gland secreting pituitary hormones. A thyroid adenoma is a glandular tumor of the thyroid gland secreting thyroid hormone. And an adrenal adenoma is a benign tumor of the adrenal gland, glandular tumor secreting some type of steroid hormone. And we're going to look at these three different pathologies in a fair amount of detail. Now, what happens with individuals who have these adenomas is they become symptomatic because they're secreting too much of a specific type of hormone. So a thyroid adenoma secreting a bunch of excessive amount of thyroid hormone causes that individual to become hyperthyroid. So endocrine pathology is all about too much and too little. Too much is hyper, too little is hypo. These adenomas often cause an individual to go into a hyper state. And depending on what type of tumor it is, what type of glandular tissue that tumor arose from, different types of tumors may be released from these adenomas. If the adenoma is in the brain, specifically on the pituitary gland, so look in the middle picture there, you can see the MRI of a big pituitary gland, and then look at the gross pathology, look at the base of the brain, and you can see this big enlarged tumor at the base of the brain at the pituitary. The individual not only will become symptomatic due to the release of the hormone or hormones, but that individual will also become symptomatic due to the effect of the pressure of the tumor on the brain. They develop elevated intracranial pressure, something we're going to talk a lot about in the neurology unit, but we're going to mention that briefly as we go through these different adenomas, particularly the pituitary adenoma. Okay, we're going to push on. So let's start with the thyroid gland. The thyroid gland is a butterfly-shaped gland that has two lobes, a central bridge, and that thyroid gland sits on top of the trachea. The thyroid gland is immediately below the laryngeal cartilage, below your larynx. So talk to yourself for a little bit, put your thumb and your index finger on your Adam's apple on your larynx. You'll feel that vibration. The thyroid gland is immediately below that. Now, the thyroid gland itself is fairly flat, so it's difficult to palpate. An individual who has an enlarged thyroid gland, that's referred to as a goiter. An enlarged thyroid gland is usually easy to visualize with your eyes. You can see it, and you're usually able to palpate it. But a normal thyroid, a normal flat thyroid gland is difficult to visualize and palpate. The thyroid gland does not wrap 360 degrees around the trachea. It kind of wraps more closer to 180, 260 degrees, so it's not completely around it. Embedded in the thyroid gland is a separate gland referred to as the parathyroid gland. You recall from last week, we talked about parathyroid hormone. Remember, the role of parathyroid hormone is on osteoclast cells to chew up trabecular bone and release the inorganic mineral deposits into systemic circulation. The thyroid gland itself secretes thyroid hormone, and thyroid hormone is a combination of two products, T3 and T4. Okay, so we say thyroid hormone, we're referring to both T3 and T4. Looking at the histology of the thyroid gland has a couple of different types of cells in it. It has follicular cells. These are epithelial cells in a single layer which circle around and line a gelatin referred to as colloid. And then there's some epithelial cells in there which are not directly adherent to the colloid. Those are the parafollicular cells. So thyroid hormone comes from the follicular cells, and calcitonin comes from the parafollicular cells. And you've heard of calcitonin, again, last week. Calcitonin does the opposite of parathyroid hormone. It acts on bone osteoblasts to build the bone and mineralize the bone, right? So parathyroid and calcitonin are acting two different ways on bone. And both of those are coming from very close proximity to each other. Parathyroid hormone from the parathyroid glands and calcitonin from the parafollicular cells of the thyroid. T3 and T4 each have iodine as part of its chemical structure. The thyroid gland is the only gland in the human body which utilizes iodine. And do you know, from a dietary standpoint, where do we get the majority of our dietary iodine? At least in the United States and in developing and in non-developing countries, the majority of our iodine intake comes from salt, iodine being supplemented into salt. But a natural source of iodine, seafood, shellfish, tends to be there tends to be a high amount of dietary iodine in those types of foods. Here is the hypothalamic pituitary thyroid axis. So out of the hypothalamus comes the releasing hormone called TRH. TRH is released into that capillary portal to the anterior pituitary gland, and it stimulates the anterior pituitary gland to secrete and release TSH, thyroid stimulating hormone. Thyroid stimulating hormone from the pituitary gland is released into circulation. It finds its way to the thyroid. It stimulates those follicular cells of the thyroid gland to build, synthesize, and release thyroid hormone into the body. And then thyroid hormone T3 and T4 will have its physiologic effects on the body. So that is how we stimulate thyroid hormone release. When we have enough thyroid hormone and the body wants to shut down, remember the end organ hormone, in this case T4 and T3, can feed back in both long or short loop, long loop to the hypothalamus, short loop to the anterior pituitary gland, and put the brakes on TRH and TSH. TSH is actually a protein hormone. It's made up of two different proteins put together. And what does TSH do? TSH has its effect on the thyroid gland. On the thyroid gland, TSH will stimulate the thyroid gland to take up iodine molecules and put that iodine into the thyroid follicle. TSH stimulates growth of the thyroid cell gland, growth of the thyroid cells, so the gland actually grows under the stimulus of TSH, and then TSH stimulates the release of T3 and T4. Here is a cartoon graphic of the thyroid gland. So we're looking at the colloid gel in the middle, surrounded by those epithelial follicular cells. So we got to get iodine out of the diet, absorbed into blood, and we got to get that iodine into the colloid. And that is the job of TSH. TSH stimulates that transporter protein. You see that there's a protein on the cell membrane that places iodine into the cell, and that then moves that iodine into the colloid space. That is stimulated by TSH. In the colloid space is a big globular protein called thyroglobulin. On that thyroglobulin are amino acids, tyrosine amino acids, and the target for iodine are the tyrosine amino acids. One molecule can be placed on a tyrosine, or two iodine molecules can be placed on a tyrosine, and we get either monoiodotyrosine or diiodotyrosine, and then we can combine those up to make T3 and T4. So it's called T3 because it has 3 iodine molecules. It's called T4 because it has 4 iodine molecules. So summarize it. In the thyroid gland, we got colloid. Inside that gel is a big protein called thyroglobulin. On the thyroglobulin are tyrosine molecules. The target for iodine going to the thyroid gland is to get that iodine onto the tyrosine molecules. Once that iodine gets to and bound to the tyrosine molecules, then we can combine them up and make T3 or T4, where T3 has 3 iodines and T4 has 4. And that process is regulated and stimulated by TSH, thyroid stimulating hormone. There's T4 and there's T3. There's something called reverse T3. Forget about that. Don't even worry about it. Let's just focus on T4 and T3. And if you look at the chemical structures, you can see the iodine molecules, right? See T4 with 4 iodines on it, T3 with 3 iodines on it. The combination of T4 and T3 is referred to as thyroid hormone. T4 is kind of like a reservoir. It's kind of inactive. You have to convert T4 to T3 to get active hormone, okay? So T4 kind of is a reservoir. We have a bunch of T4 floating around, and then when we want physiologic effect, we are going to take off an iodine. They call it deiodination, removing an iodine. So we go from 4 to 3, T4 to T3, and that T3 is what has the majority of the biologic activity, majority of the physiologic function of thyroid hormone. So what do they do? What is the physiologic effects of thyroid hormone? So again, we have higher concentrations of T4 than we have of T3, but T3 is far more active than T4. T4 hangs around in plasma for about a week. T3 hangs around for a day. So you can see that T4 can act as a reservoir. We can draw on T4 to get more T3. And then what does thyroid hormone do? Thyroid hormone is responsible for growth. Thyroid hormone is responsible for development and differentiation of the central nervous system, particularly in utero and early on as infants and children and teens as our brain is going through critical development. T3 helps the heart contract, so it's very important in providing energy for the heart, which produces cardiac contractility. T3 is responsible for energy expenditure. So when we need to burn energy for fuel, T3 plays a role. And T3 is also responsible for maintaining core body temperature. So a lot of different physiologic effects by one hormone. And the way that one hormone can have so many different types of physiologic effects is that hormone acts on DNA. And by acting on DNA, DNA will copy, and then the cell will start to synthesize and release the enzymes and the proteins necessary for all this physiologic effect. Okay, so the quick summary here, thyroid hormone is a combination of T4 and T3. We have more T4 than T3. It acts as a reservoir. In order to activate that T4, we have to convert it to T3. T3 then acts on DNA, activating critical genes necessary for these primary 5 critical physiologic functions: growth, development of the central nervous system, cardiac contractility, energy expenditure, and maintaining core body temperature. This is just a quick graphic showing you T3's ability to bind to DNA. T3 doesn't directly bind onto DNA. T3 binds onto this protein referred to as TRE, the thyroid response element. When T3 binds that thyroid response element, then it starts activating genes. I'm happy with you understanding that. In order for T3 to have its physiologic effect, it has to activate critical genes on DNA. I'm not too worried about you knowing the function of this TRE protein, but just understand that it's kind of like the intermediary. It's what gets T3 to the DNA, if you will. Okay, so a goiter is swelling of the neck due to thyroid gland enlargement, right? A goiter does not necessarily state whether a person is hypothyroid or hyperthyroid. The physiologic action, what the patient has in terms of symptoms, determines whether they're hypo or hyperthyroid. And a goiter can go either way. Some individuals with a goiter are hypothyroid. Some individuals with a goiter are hyperthyroid. So let's take our fictitious patient here. Let's call her Kelly. She's 19 and you can see her goiter, right? And you'd be able to palpate that, and that would be fairly easy to see and feel that enlarged thyroid gland. Now you want to look at her and you want to say, okay, is she hypothyroid or hyperthyroid? And you're going to do that based on the signs and symptoms that she has and based on her blood levels of TSH and T4 and T3. So let's do the easy one first. If she's hypothyroid, low, what's her blood levels of T4 and T3? Low or elevated? Simple, right? They're low. And if she's hyperthyroid, what's her blood levels of T4 and T3? They are also going to be elevated. Now, TSH is weird. In each case, TSH may be up or down depending on where the pathology is. So we'll come back to that in a second. What I want you to do now is stop the recording and think about what does she look like in terms of temperature, cardiac, weight, skin, eyes, GI tract, and mood if she's hypothyroid. And then what does she look like in terms of temperature, cardiac, weight, skin, eyes, GI tract, and mood if she's hyperthyroid. I'll stop for a second here. Okay, you're back. Hopefully you did that. Okay, if I told you that she was excitable, anxious, sweating, losing weight, tachycardic, and having diarrhea, you would say that she is which of the two? Hyper. Yes. And if she were lethargic, depressed, skin was very dry, she was putting weight on, constipated, always feeling cold, you would say that she is hypothyroid. Right. So hypothyroid, low T4, T3, hyperthyroid, too much T4, T3. Each one is going to give her a different physiologic presentation. There are numbers of different thyroid disorders. And here I've listed 1, 2, 3, 4, 5, 6, 7, 8 different thyroid disorders. What I want you to do is look at each of these 8 disorders, and I want you to tell me, would the person be hypo or hypothyroid in terms of the physiology? And then if you really wanted to be good about this, what do you think would be the TSH level in that individual? Do you think it would be elevated or low? And that's difficult. That one's the harder one to do because remember, you have to account for negative feedback. So if somebody is really hyperthyroid and they've got a lot of thyroid hormone being secreted, that thyroid hormone is going to go back and try to shut itself off, lowering the TSH level. But if you have a pathologic process which is actually causing TSH levels to rise, such as a tumor in the pituitary gland, which is synthesizing TSH, or an autoantibody, which is stimulating the pituitary gland to secrete more TSH, then those TSH levels go up. So let's think about it. I want you to spend a little bit of time on that. Look at each one of these. And at minimum, you should be able to tell me, is the individual more likely to be hypo or more likely to be hyperthyroid? Let's take a couple of these and help you out. So the easy one, if the person was malnourished and markedly deficient in iodine intake, which way are they going to go? High or low? Hypothyroid, right? If they had a hypersecretory tumor of the thyroid gland, so they had an adenoma secreting a bunch of T4 and T3, which way would they go? Hyper, right? And if they had a brain tumor, and this brain tumor was on the pituitary gland, and this particular tumor was destructive to the pituitary gland, rendering the pituitary gland dysfunctional, not able to secrete hormone, which way would this individual go? Hypo, right? And would you agree with me that a destructive tumor of the pituitary gland would also make the TSH levels low as well, right? Because that tumor is destroying the pituitary gland, therefore if it's destroying the gland, it can't make the TSH. So try those out. There's 3 of them. See if you can deal with the other ones. We can talk that out on Blackboard, and you can also post that as a question. You know, that's totally legitimate. If you're having a hard time with it, just post that as a question on Blackboard and say, hey, somebody help me out. I don't understand Graves' disease or whatever, okay? All right, move on. Now, let's talk about thyroid cancer. So let's look in the middle histology, where it says normal histology. That looks like a normal thyroid gland. Now look immediately above it, and what do you see different about that photo versus the normal thyroid gland? Would you agree with me that all those cells look different? They vary in their nucleus, their nucleoli. There's abnormal mitotic figures. They seem to be all over the place. They've lost polarity. What's the term that we give that? Anaplasia, right? And when we're talking about anaplasia, we're talking about cancer. Exactly. So let's look at cancer. And here we're looking at cancer, thyroid cancer in terms of the histology. We're looking at thyroid tumors being exposed in a surgical section and in a gross pathology section. And then we're also looking at a big thyroid tumor on the CT scan. See it in the upper left there. And then if you come down to the bottom CT scan, we're looking at heart and lungs, and you see all this white tumor all over the lungs. That would be representative of metastatic thyroid cancer to the lungs. So let's talk a little bit here about thyroid cancers. Thyroid cancers are not that common, count for somewhere less than 4% of all cancers. American Cancer Society says there's about 600,000 new cases per year, about 1,500 fatalities per year. Thyroid cancer, primary thyroid cancer, is going to originate on the thyroid gland. So common presentations of thyroid cancer would be neck swelling, neck pain, Individual would develop a hoarse voice, particularly if that cancer is involving the larynx or involving the nerves going to the larynx. Individual may have pain on swallowing. An individual may have enlarged lymph nodes if those lymph nodes now, if that cancer now becomes metastatic into the lymph nodes. In terms of the endocrine effect, what do you think is more likely to happen to an individual with a destructive thyroid cancer? Are they more likely to get hypo or hyperthyroid? More likely to get hypothyroid. If they had a benign secretory adenoma, it's a different type of tumor now, benign secretory adenoma of the thyroid gland, that tends to pump out thyroid hormone and you get hyperthyroid. But individuals with destructive cancers lose the ability to synthesize and release thyroid hormone. They tend to be hypothyroid. Okay, so now some more definitions. A goiter is an enlarged gland. A nodule is a lump in the gland, and a nodular goiter is multiple nodules increasing the size of the gland, okay? And the thyroid can go one of three ways. You can get a goiter, which is just enlargement of the entire gland. You can get a nodule, which enlarges within the gland, or you can get the entire thyroid gland enlarged because of a bunch of nodules. That would be called a nodular goiter, okay? Most nodules are benign. They're cysts. They're filled with fluid and colloid. You can aspirate that fluid and colloid and find out that it has no cancer cells in it, so that would be referred to as a benign nodule. About 1 in 20 of these thyroid nodules are solid, and it's the solid ones that tend to be malignant. So if you have an individual who you palpate a solitary nodule on their thyroid, what you eventually going to want to do is you're going to want to differentiate that as being fluid-filled versus solid. And remember, the solid ones are the ones that tend to have more likely be cancerous. So we can use ultrasound, MRI, we can biopsy it and look at the histology and come up with a diagnosis as to whether or not this is a benign cystic nodule or a malignant nodular cancer. Being exposed to radiation, repeated exposure to radiation is probably the biggest single cause of thyroid cancer. So you guys all go down, maybe some of you work directly in radiology. Certainly a lot of you go down to radiology. You know that the people working all the time in radiology are wearing dosimeter badges. They tend to wear the lead shield around their neck, right? You're trying to prevent radiation exposure to the thyroid, minimizing your future risk of thyroid cancer. Extremely important. Females tend to have a higher incidence of thyroid cancer versus males. And again, remember this term oncogene. Individuals who carry certain type of oncogenes may also have an increased predisposition to thyroid cancer. Remember, all cancers come from DNA mutations, and all cancers have a cell of origin. So when we're talking about thyroid cancer, primary thyroid cancer, we're talking about cells within the thyroid gland that develop a DNA mutation that therefore went on to lead to the malignancy. There's two primary types of thyroid cancer. There's well-differentiated thyroid cancer. Those are cancers that come from those epithelial cells lining the colloid. And then we have less differentiated thyroid cancers. Those are cancers that arise from other cells found within the thyroid gland. I'm not going to spend too much time on those. Sarcomas, lymphomas of the thyroid gland, those are cancers that started in the thyroid that did not originate from those follicular epithelial cells. The thyroid cancers that originated from those follicular epithelial cells tend to be a little bit better differentiated. They tend to show a better prognosis. they tend to have lower rates of metastatic disease. 75% of those are considered to be papillary thyroid epithelial cancers. Those are the ones that tend to have the best prognosis. And remember, those epithelial cells of the thyroid gland are the ones that take up iodine. So one way that we can treat these types of cancer is to give the individual radioactive iodine. That radioactive iodine will be taken up by those malignant follicular cells, and then that radioactive iodine will essentially kill those cells. So it's a radiation, it's kind of like a combination of chemistry and radiation put together to treat that type of thyroid cancer. And again, that's only going to be beneficial for those follicular epithelial cancers because those are the cells that can take up the iodine. Those other less differentiated types of cancers tend to not respond at all to that radioactive iodine. And again, after a biopsy is taken, a good pathologist is going to look at that and tell you what type of cancer you're dealing with. So what do you think? If you were given this biopsy and you were told that that biopsy came from the thyroid gland, can you see the anaplasia in here? And again, once you see anaplasia, then you know you're dealing with a malignancy. What defines anaplasia? The lack of architecture, the lack of polarity or how those cells are aligned, marked variation in the size and distribution of the cells, marked variation in the size of the nucleus, abnormal mitotic figures, right? All that we've been talking about in every unit so far. We've talked a little bit about cancer, and again, we will keep highlighting these different types of cancers as we move through this course. All right, what do we call enlargement of the thyroid gland? We call that a goiter. If we see an enlarged thyroid gland, we want to do a careful palpation to determine whether or not that enlargement is due to a single solitary nodule or due to multiple nodules. Look at this young lady with the goiter, and then look at the post-surgical section. You see all those nodules. Kind of like that would be nodulocystic because all those nodules are fluid-filled. So her thyroid gland has been enlarged due to a number of nodules. If we find the solitary or multiple nodules on someone's thyroid, we want to determine whether it's solid or cystic. So how can we do that? What do you think would be an easy way to determine if something is solid or cystic? You can put your answer in the red box there. I would say you do an ultrasound because the ultrasound can then tell you if it's fluid-filled or solid, right? And then how can we determine if it's benign or malignant? We're going to want a sample of it. So what can we do under ultrasound? We can take an aspirate or take a biopsy, right? So an ultrasound-guided aspirate or biopsy of the thyroid gland, done by somebody who knows what the hell they're doing, right? Done by a surgeon or a interventional radiologist who does those type of procedures, right, can then determine what it is that we're dealing with in this young individual with the goiter. And there again, here you can see, can you see the goiter in each of these individuals? Would you be able to palpate it? And would you be able to palpate that as being one nodule, one mass, or a bunch, right? That becomes an exam skill, being able to palpate that and then being able to differentiate by palpation. Are we dealing with one thing or a number of different nodules on that gland? And then an ultrasound to differentiate it, right? Solid versus cystic, and then the needle aspirate. And there you can see in the cartoon, you can see that a needle aspirate is being done of a solitary cystic nodule on that individual's thyroid gland. So what you guys should be doing, as you're learning more pathology, and you're probably already doing it because you're already nurses and clinicians, when you're walking around, look, can you recognize goiters as you're, walking through Wisconsin State Fair or sitting at church or, wherever you might be. Don't be creepy about it. Don't be a stalker. But, it's okay for you to look around at and see if you can visualize pathology. And that's one pathology that you should be able to visualize as you're looking at individuals is, can you appreciate whether or not they have a goiter? Okay, now look at each of these following individuals and determine, just based on what they look like, do you think this individual is, well, first off, can you see a goiter? And then secondly, by looking at each of these individuals, can you determine if they are hyperthyroid or hypothyroid? And again, think about the physiologic effects of hyperthyroidism, the physiologic effects of hypothyroidism, and you should be able to look at these pictures and determine which of the two the individual is most likely to be. But again, confirming hyper and hypothyroidism, you're going to look at those T4 and T3 levels, right? Elevated T4, elevated T3, hyper, low T4, low T3, hypo. Brief bit of pharmacology here. If we have an individual who is hypothyroid, they are not secreting adequate amount of thyroid gland, and that can be quite threatening. It could be very symptomatic, and that can actually be life-threatening depending on how severe it is. We're going to want to supplement them with thyroid hormone. The most common way to do that is to give the individual T4, not T3. Most individuals who are hypothyroid get supplemented with synthetic T4 in an oral tablet, and that oral tablet is referred to as Synthroid, and you can see a number of different Synthroid tablets at the bottom there, all having varying dosing. The typical way to start treating somebody with hypothyroidism is to start them with a low dose of Synthroid and then start to titrate up to get them controlled back to a normal thyroid state. Now, I'm not saying that T3 is never used. There are some times where individuals have such severe life-threatening hypothyroidism that you have to give them tablets which contain T3. But the majority of times when you're treating an individual with hypothyroidism, you're treating them with Synthroid and you're giving them T4. The benefits to doing that is it will mimic the natural distribution of T4 and T3. The individual will take that T4 and convert it, metabolically convert it to T3. Remember, T4 lasts for a longer period of time. They'll develop some reservoir as they're taking the T4. And it's easier to titrate versus T3. It's a little more difficult to control somebody, give them the active hormone versus giving them the hormone which the body is going to metabolically convert. And then because of its long duration, you only need to dose them once a day. Synthroid still falls into one of the top 10 most frequently prescribed generic drugs in the United States. And that just tells you there's a lot of people that suffer from hypothyroidism. All right, let's stop for a second here and talk about weight loss. So what happens to individuals who are hyperthyroid in terms of their weight? A hyperthyroid individual is almost always going to be losing weight, right? They tend to be agitated, sweaty, tremorous, tachycardic. They often have diarrhea, and they lose weight. So what some people do is they see this on the internet and they say, hey, I can buy some thyroid hormone on the internet and I can lose some weight. And what they're purchasing, usually what they're purchasing is they're purchasing a tablet which has been made from cow or pig thyroid gland. It's desiccated thyroid gland, where desiccated means dry. So you're getting dried animal thyroid gland in these tablets, and within that dried animal thyroid gland is the animal T3. It's the pig T3 or the pig T4. And it's physiologically active in humans. So they start taking that and they start losing some weight. It's effective. You'll lose some weight doing this, but then what's going to happen to these individuals? They're going to become hyperthyroid, and these individuals can very rapidly develop the severe cardiac consequences of hyperthyroidism, which includes high output congestive heart failure and cardiac arrhythmias. Don't do this. Don't let your patients do this. Can you lose weight taking desiccated animal T3 products? Yeah, you can. Are you destined for hyperthyroidism and cardiac consequences as a result of it? Yes, you can. And in my role as a clinical toxicologist with Medical College of Wisconsin, I saw numbers of individuals who were doing this. A lot of them ended up in the hospital with pretty significant hyperthyroidism. And without being too sexist, I will say that every single individual who I saw do this were female, young females trying to lose weight. Don't do this, okay? This is dangerous. And I will also tell you that a personal friend do this, and she ended up in the ICU in SVT and heart failure from taking this. She passed out one day at work, and in her resuscitation was found to be in SVT. And in her workup, when they found out she had lost all this weight, in her workup, they found these markedly elevated levels of T3, and then she finally came around and told people that she was taking the stuff. Don't do it. Go on the internet today, or go on the internet at some point and put in a search for desiccated animal T3, and you can see how easy it is to find this stuff. But again, please don't do this. Enough of thyroid. Let's move to our next end organ, and that's going to be the adrenal gland. And we're going to first talk about the innermost portion of the adrenal gland, referred to as the adrenal medulla. A hormone that comes out of the adrenal medulla is epinephrine. Remember, our definition of a hormone: a substance synthesized and released from one organ into the bloodstream to have physiologic effects on other distant organs. So when the adrenal medulla synthesizes epinephrine, releases that into the bloodstream, and then that epinephrine has physiologic effects on organs outside of the adrenal gland, epinephrine then fits that basic definition of a hormone. The adrenal gland has a number of different parts to it. There's an outer shell called a capsule. Kind of holds it together, not a whole lot of physiologic activity going on. The innermost region is the medulla, and then there's three regions in the middle: glomerulosa, fasciculata, reticularis. I'm not going to hold you responsible for those three names, but we're going to get to that other part of the adrenal gland when we talk about steroid hormones. First, we're going to talk about epinephrine as a hormone of the adrenal gland. Remember, the adrenal glands, we have two adrenal glands, and they sit right on top of each of the two kidneys. The adrenal glands, particularly the adrenal medulla, synthesize and release two substances, norepinephrine and epinephrine. These two substances are catecholamines. The chemical structure, so if you guys remember any chemistry, on the right side of the molecule is the nitrogen amine, and then you come to the phenol ring, right? That benzene ring, the benzene ring, and then there's two hydroxyl groups. So when you see that amine, benzene, two hydroxyls, that's called a catecholamine, right? Norepinephrine and epinephrine are two types of catecholamines that have tremendous physiologic function in the human body, each synthesized and released by the adrenal gland. Oh, what is this? This looks creepy. Who are we looking at here? You guys may recognize this dude from a number of creepy movies. If you're into the genre of slashers, right? You know that there's a number of these different types of movies. So who is this? Is this Freddy? Is it Jason? Is it Michael? Is it Leatherface? It is. That's Michael Myers, right? So if you're a fan of these type of movies, Michael Myers was the villain in the Halloween movies, and there's 47 different Halloween movies out right now, which has this individual, and this individual goes about randomly attacking people, right? So what would you do if all of a sudden, you were sitting alone and you turned around and there was Michael Myers coming at you, right? You would go into what's called the fight or flight crisis, and you would do anything that you could to either get away from this guy or fight this guy to save your life, right? So this is a true physiologic effect that we experience at times of peril. We can rapidly go into the fight or flight crisis. And our ability to go into the fight or flight crisis is primarily dependent on activating and releasing these catecholamines like epinephrine and norepinephrine. Those catecholamines will be released, act within the part of the nervous system referred to as the sympathetic nervous system, and then they will have effect on a variety of different tissues within the body to allow us to save ourselves in either fight or flight. So let's think about this for a second. We can use another scenario too. Let's say that you were walking through the woods and now you came upon a rattlesnake or a cougar or whatever. You're in some situation where you experience peril. What do you want happen with respect to your muscles, your vision, your heart, your lungs, your GI tract, your liver, and your genital urinary and GI sphincters? Think for a second, stop the recording, and just think, okay, if I had to save my life, what do I want to happen? Okay, I'm going to stop. Think about it. All right, you think about it? Okay, I'm back again. All right, muscles. You want increased muscle contractility. Vision, right? You want your kind of eyes to dilate so you get more light through your retina so you can see better. You want your heart pumping harder and faster, giving you more cardiac output. You want more air moving through your lungs. You want to dilate your bronchial tubes, get more oxygen into your lungs. You really don't need to be digesting food, so you can shut down your GI tract and you can stop peristalsis. You want your liver to not be storing energy but pumping energy out, right? You want to be busting down all your stored carbohydrate and releasing it as glucose to get all that energy to your cells. And when you're running away from the bear or Michael Myers or whatever it is you're doing to save yourself, that's not the time to stop and, void and, take a leak or visit the facilities, right? So you want your bladder sphincters and your rectal sphincters to kind of like zip up and, hold everything intact there. And this is all part of the fight or flight crisis, okay? And that is mediated through the sympathetic nervous system under those catecholamines, norepinephrine and epinephrine. Here is the autonomic nervous system. The autonomic nervous system is all about sending innervation to the internal organs. We have the blue side, which is the sympathetic side. That's all about fight or flight. And then we have an exact opposite side, the parasympathetic side, and that's referred to as rest and digest. So physiologically, when you're running away from a bear, your body is acting differently than when you're sitting on the couch eating pizza and watching Downton Abbey or whatever you like to watch, right? Two different physiologic things happening, right? Sympathetic fight or flight, parasympathetic rest and digest. The sympathetic side is mediated by those catecholamines, epinephrine and norepinephrine, and the source of those catecholamines is the adrenal medulla. So the adrenal medulla can very rapidly release those catecholamines and very quickly put you in fight or flight crisis. And you know that because if you've ever been in such a situation, you know that you can very rapidly respond to something like that, and you feel your muscles contract, you start sweating, you feel your heart rate going up, you can probably feel palpitations right? And if somebody were looking at you, they'd probably say, wow, your eyes are really dilated, right? Fight or flight crisis, sympathetic side of the nervous system mediated by the catecholamines. Now, the catecholamines, when they get to the end organ, they have to have a site to contact. They have to have a receptor. So remember, all signaling messages that move around the body, whether it's a hormone, whether it's a catecholamine, whether it's an ion, no matter what it is, it has to have some point of contact with a cell, and that point of contact is referred to as the receptor. So norepinephrine and epinephrine are acting on the receptors of the sympathetic nervous system. Those receptors are named either alpha or beta. We have 2 types of alpha receptors, alpha 1 and alpha 2. 3 types of beta receptors, beta 1, beta 2, and beta 3. This is extremely important in pharmacology when you get to pharmacology and start talking about different drugs that affect alpha versus beta receptors. It's in physiology courses and pathophysiology courses that you should learn about these receptors, understand where those receptors are, and physiologically what those receptors are responsible for. So the way that you do this is, rather than just staring at this table for a half hour, is to write this table out a couple of times on your own. Because if you write it out, you make more synapses, right? You learn better. I think this has been proven. When you take something and you write it out, you're going to learn it quicker, and it's going to stick to you better than if you just try to look at it and memorize it. So we're going to talk more specifically about each of these receptors as we move into the different organ systems. For now, I want you to understand sympathetic versus parasympathetic, fight or flight versus rest and digest, catecholamines acting on the alphas and the betas. And then as we get into the different systems, we get into cardiovascular and pulmonary and renal, then that will be the time then to know specifically what does beta 1 do versus beta 2. So right now today, I'm not too worried about it, but you are going to, I want you to be able to know that as we move further through the course, okay? And here it is. It's all set up for you, alpha and beta. Okay, that's the normal physiology. Let's talk about one pathology of the adrenal gland, and that is a tumor referred to as a pheochromocytoma. I'm sure some of you guys have seen this. A pheochromocytoma is relatively rare, estimated that about 1 in 100,000 people have this tumor. It's a secretory tumor of the adrenal medulla. So what does the adrenal medulla normally synthesize and release? Catecholamines, right? So if this is a secretory tumor of the adrenal medulla, what would you expect this tumor to be releasing? Catecholamines, right? Specifically epinephrine and norepinephrine. So another term that we can use for this tumor is an adenoma, right? A secretory tumor, an adenoma. But the pheochromocytomas are typically not malignant. They're typically not cancerous. Doesn't mean that they're without consequence, because the consequences can be very significant due to the release of the epinephrine. And one of the biggest consequences of a pheochromocytoma is profound hypertension. Remember that epinephrine and norepinephrine raise your blood pressure. So now if you have a tumor which is secreting excessive amounts of epinephrine and norepinephrine, that individual would be expected to have pretty significant hypertension. And usually they have such severe hypertension that it's very difficult to control with medications. So always think about that. Severe hypertension not being controlled with antihypertensive medications, you got to consider maybe this individual has a pheochromocytoma. So remember, it's a tumor of the adrenal gland. The adrenal gland is found at the top of the kidney. So look at the CT scan. You can see the vertebral column. Centrally, you can see the liver on the right, the spleen on the left. You can see the 2 kidneys on each side. And then on the patient's left side there, you can see that large tumor on top of the kidney. There is a histologic view of what a chromocytoma looks like, and there is a surgical specimen where the adrenal gland has been removed. Remember, the adrenal gland is kind of like a triangular shaped organ, and then you can see that big tumor right in the middle. It starts in the medulla and it grows, and it kind of grows outward. And again, it's not cancer. It's a benign tumor, but it does have physiologic consequences. So most PHIOs are unilateral. Most people only have one. They tend to be fairly vascular. You often cannot palpate it on an individual, so even with really good exam skills, you probably could not palpate a pheochromocytoma. But it would be suspected in an individual who has severe hypertension and all these other symptoms of the fight or flight crisis, right? So you have an individual who's constantly hypertensive and anxious and sweating and tremorous and losing weight, right? All this stuff that we see in the fight or flight crisis, got to consider this person may have a pheochromocytoma. This tends to be a tumor of young adults. Very often they have very difficult to control blood pressure. Their symptoms tend to come on suddenly, and their symptoms tend to be recurrent due to that persistent and intermittent release of the catecholamines. These catecholamines can be picked up in blood or in urine. Sometimes they're looking directly for the catecholamines. Sometimes they're looking for the breakdown product of the catecholamines. So the metanephrines are the breakdown products of norepinephrine. Individual has the symptoms with high amounts of these catecholamines and metanephrines in their blood or urine. Then do an MRI, find the tumor on the MRI, and then and then be referred to a surgeon who specializes in these types of surgical removals. So again, the treatment for a pheochromocytoma is not medical, it's surgical. It's to resect the tumor. Okay, that was the adrenal medulla. Now let's stay in the adrenal gland, but let's move to the adrenal cortex, those three other layers, the glomerulosa, the fasciculata, reticularis. Combined, those three form the adrenal cortex. And from the adrenal cortex, we synthesize and release steroid hormones, and the steroid hormone that we're going to spend the majority of our time talking about now is cortisol. Okay, here's the hypothalamic pituitary axis for the adrenal cortex. Again, it all starts in the hypothalamus synthesizing and releasing a releasing hormone into the capillary portal. That releasing hormone is called CRH. CRH travels to the anterior pituitary gland. In the anterior pituitary gland, it will stimulate the release of ACTH, adrenal corticotropic hormone. That's the stimulating hormone that gets into the bloodstream and will find the adrenal cortex. In the adrenal cortex, ACTH will stimulate the growth and the activity of the adrenal cortex, and by doing so, the adrenal cortex will release the end organ hormone, in this case, cortisol, and then cortisol is going to have a variety of physiologic effects around the body. We can self-regulate the amount of cortisol in the same way that we can self-regulate the amount of T4 and T3 being released through the negative feedback loops. The short loop back to the anterior pituitary and the long loop back to the hypothalamus. Remember, only the end organ hormone has the ability to have this negative inhibitory feedback control. So remember, the adrenal gland has the adrenal medulla, synthesizing and releasing the catecholamines, particularly epinephrine. The adrenal cortex synthesizes and releases the steroid hormone. So the cortex are the three other areas of the adrenal gland: glomerulosa, fasciculata, reticularis. Don't worry about those three names. but understand the cortex is a different region than the medulla. Within the cortex, we are synthesizing and releasing steroid hormones. Now, gonads, testes, and ovaries also synthesize and release steroid hormones. But the gonads are under the control of a different axis. They're under the control of FSH and LH. We're going to leave that alone. The adrenal cortex is under the hypothalamic pituitary control of ACTH. So ACTH is going to stimulate the adrenal cortex to synthesize and release these steroid hormones. Now, what is the building block of all steroid hormones? So steroid hormones have to be synthesized. What do we use as the building block to make these hormones? It's cholesterol. So cholesterol does get a bad rap, right? You know, cholesterol will build up in your arteries and give you heart disease. So yeah, it will. But without cholesterol, we wouldn't live very long. Cholesterol is an integral part of cell membranes. Cholesterol is a building block for critical steroid hormones. All these steroid hormones have what's this structure right here. They have what's called the steroid nucleus, 4 rings, 3 6-membered rings, and the 5-membered rings. Those 4 rings are referred to as the steroid nucleus. And as we look at all these different steroid hormones, you're going to see a lot of similarity between them. Now, if you're really good at chemistry, and if you wanted to, I could teach you how to look at all these different hormones and identify them all by the chemical structure, but we're not going to do that. But I am going to want you to know the different steroid hormones and what their effects are. Okay, I'm going to be light on you guys in terms of the chemistry. Okay, 3 types of steroid hormones: glucocorticoids, mineralocorticoids, and sex hormones. The hallmark glucocorticoid is cortisol. The hallmark mineralocorticoid is aldosterone. 3 different types of primary sex hormones: testosterone, estrogen, and progesterone. And in this course, we don't really go through a whole lot of reproductive physiology and reproductive pathophysiology, so we're going to kind of leave those alone. We're going to focus on this unit on cortisol, and then when we get into the renal unit, we'll focus more on aldosterone. 3 types of steroid hormones. Only one type of steroid hormone has anti-inflammatory effects, and those are the glucocorticoids. So we have all these different steroids floating around the body, but only one type of steroid is anti-inflammatory, and that is cortisol. So therefore, if we wanted to give a patient an anti-inflammatory steroid, the only type of drug that we could give them would be a drug that looks like and acts like cortisol. Estrogen in birth control tablets, progesterone in birth control tablets, testosterone in androgen hormones. Those are steroids, but they're not anti-inflammatory. Only the glucocorticoids are anti-inflammatory. That's a very important pharmacologic point to make. Okay, see cholesterol up there at the upper left? That's the building block, and you can take that cholesterol and you can put it through the adrenal cortex, and you can put it through the gonads as well, and through a series of different cytochrome enzymes, what they call cytochrome P450 enzymes, you can make all these different steroid hormones. So you can see progesterone, you can see cortisol, aldosterone, you can see the androgens, testosterone, you can see the estrogens, right? So we're building all that off cholesterol, and there's a very complex synthetic pathway in order to get to all these different hormones. I'm not going to test you on anything on the slide, but I do want you to understand that in the gonads and in the adrenal cortex, we have this going on. So males have testes, females have ovaries, but both males and females have adrenal glands, right? So it's through the adrenal glands that men can have endogenous estrogens, and through the adrenal glands that women can have endogenous androgens. Men need estrogens. They tend to have more androgens. Women need androgens, but they have more estrogens, okay? So both genders, we can make all these hormones because of the adrenal glands. Just another look at it here. Cholesterol being taken through the different enzymatic pathways to make the glucocorticoid cortisol, the mineral corticoid aldosterone, and the sex hormones, progesterone, testosterone, and the estrogens. Cortisol is regulated by ACTH. So ACTH stimulates the enzymes of the adrenal cortex necessary to make cortisol. Cortisol is a stress response hormone. It is very much catabolic. Under the influence of cortisol, we break down energy into substrate. We burn glucose, we burn fat, we burn protein. That's catabolic, all right? Cortisol plays a huge role in the fight or flight response. Cortisol with the catecholamines work together to give us that effect that we need to make all that physiologic effect happen in the fight or flight response. The other big action of cortisol is it is anti-inflammatory. It tampers down the immune system, okay? And again, what did I say about the glucocorticoid steroids with respect to inflammation? Correct. Only the glucocorticoid hormones, cortisol in particular, are anti-inflammatory. None of the other steroids are anti-inflammatory. Here's those three layers of the cortex again, and you can see that the glucocorticoids under the control of ACTH primarily come from that middle layer, the fasciculata layer. If you want to remember that, that's fine, but I won't test you on that. At least at a high level, understand that those steroids are coming from the region referred to as the cortex, the adrenal cortex. Once again, here is that hypothalamic pituitary axis. Remember, CRF coming out of the hypothalamus to the anterior pituitary, ACTH coming out of the anterior pituitary, and then going to the adrenal cortex to stimulate the release of cortisol. All right, other things that we do with cortisol. Cortisol is our stress hormone. Cortisol is our hormone that it's another hormone that has us seek nutrition, right? Causes us to eat. Cortisol regulates sleep-wake cycles. What do you think cortisol is more likely to do? Put us to sleep or wake us up? Wake us up, yeah, definitely. So a majority of our cortisol release happens early morning. Cortisol also regulates core body temperature. Cortisol plays some role in water balance. Cortisol regulates other circadian rhythms, but the big circadian rhythm that it helps regulate is sleep-wake cycles. So an individual who has excessive cortisol, for whatever reason, let's say an individual is making too much cortisol, are they more likely to be insomniac, can't sleep, or are they more sleepy and lethargic? What do you think? Yeah, they tend to be more insomniac, and that might be one thing that you see in an individual who is taking a steroid drug, like a cortisol-like steroid drug like prednisone, or they have a pathology of too much steroid. You see interruption in that sleep-wake cycle, and they tend to be a little bit more insomniac. The cadaver picture there just shows you some of those critical regions of the brain, where P again is the pituitary gland, H is the hypothalamus, and right above the hypothalamus is the thalamus, and we'll talk more about the thalamus when we get into the neurology unit. And then just kind of putting it all together, there's the hypothalamic pituitary axis, releasing ACTH to the adrenal cortex, stimulating the release, particularly release and synthesis of the glucocorticoid steroid cortisol. So just another way of looking at the same thing. Again, reviewing for you the different functions of the glucocorticoid hormone cortisol. Immune suppressant, catabolic, helps regulate the cardiovascular system, particularly in response to stress with fight or flight, and then very important in regulating a number of different circadian rhythms. The peak release of cortisol tends to happen in the early morning hours. So, we pose this question to you: how does one molecule, in this case this hormone, cortisol, how is it able to mediate so many different physiologic responses? And the answer is the same as we said with thyroid hormone. It has its effect on DNA. It starts to stimulate copying of critical genes on DNA to build the proteins and the enzymes necessary to give us this physiologic effect. And again, the only class of steroid hormone that has anti-inflammatory effect are the glucocorticoids. All right, let's move off this slide. A little bit different in T3, but some similarities. Cortisol gets inside the cell. It has a complex receptor that it binds to, and then that cortisol receptor complex is going to bind onto DNA and activate those critical genes. Do I need you to know this, the complexity of this cytoplasmic receptor? No. But just again, understand it's a hormone with a lot of physiologic activity. Physiologic activity is due to the fact that it can stimulate critical genes on DNA. Shutting it off. So we have negative feedback, right? That's one way to shut it off. We also have an enzyme in the body that can turn cortisol, an active hormone, into cortisone, an inactive hormone. And we can go back and forth. So cortisol can go to cortisone and cortisol can go back to cortisol. Only cortisol is active, all right? So it's just another way to regulate the effect of this stress response hormone. We can regulate it through negative feedback, or we can inactivate it through this enzyme here, this 11-beta hydroxysteroid dehydrogenase type 2 enzyme can make it an inactive hormone, okay? Just more physiology for you to take a look at. And again, glucocorticoids are very effective at suppressing inflammation and suppressing the immune system. Remember that the immune system is regulated by white blood cells being activated by inflammatory mediators. Those inflammatory mediators can be protein by nature, such as the interleukins and tumor necrosis factor, or they can be lipid by nature, such as the prostaglandins and the other eicosanoids that we mentioned all the way back to Unit 1. Cortisol has adverse effects, or cortisol can limit the synthesis and release of the lipid mediators of inflammation and the protein mediators of inflammation. So cortisol is extremely effective in tampering down the inflammatory response due to the negative effects that it has, not only directly on the white blood cells, particularly the lymphocytes and the macrophage, but also more directly on the chemical mediators of inflammation themselves. And here we are, we're just kind of summarizing for you why is cortisol such an important anti-inflammatory drug? It was because you can see it inhibits key synthetic paths which make these mediators of inflammation, and they also are toxic to lymphocytes, and they can inhibit the processing of antigens. Okay? Very effective. Now I want you to do something. On this slide, what I want you to do is get rid of that term corticosteroid and change it to glucocorticoid. Glucocorticoid is the better term. So when we're talking about cortisol, refer to it as a glucocorticoid, okay? And remember, the glucocorticoids are the only ones that suppress the immune system. So there are some times that we want our immune system to be suppressed, right? We don't want our immune system acting against ourselves, right? So one means to protect ourselves against autoimmune pathology, the immune system attacking ourselves, is by tampering that down through the glucocorticoid cortisol. So tampering down the immune system is a good thing. But again, if you tamper down the immune system, then that comes with a cost, and that can lead to increased risk of infection, right? So we got to talk about what's the effect of too much cortisol and what's the effect of too little cortisol, right? Because endocrinology is all about too much and too little. Too much we refer to as Cushing's, and too little we refer to as Addison's. Now we can say hypercortisol and hypocortisol as well, just like we say hyperthyroid and hypothyroid, but at least in terms of endocrine, they tend to more commonly refer to this as being Cushing's or Addison's. All right, so here are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 different symptoms, if you will. What I want you to do now is stop and think about this and think to yourself, is this more likely a manifestation of Cushing's syndrome, too much cortisol, or too little cortisol, Addison's? I'll give you a minute. I will stop talking, put your PowerPoint on pause here, and then talk it out. Hello, I'm back. Okay, let's go. Who has an increased risk of infection? Too much. Who has a risk of hyperglycemia and therefore worsening their diabetes? Too much. Remember, the glucocorticoid is pumping glucose out. Who therefore gets hypoglycemic? Addison's. Who's hypertensive? Cushing's, right? Because cortisol is acting with the sympathetic nervous system, fight or flight. Therefore, who's hypotensive? Addison's. Hyperpigmentation, now this one's interesting. Within the ACTH, within the molecule that creates ACTH, is also the melanin protein. So this can go either way. But an individual who's pumping out too much ACTH may also be pumping out excessive amounts of melanin, and they tend to have kind of like a tan appearance to them. We see that a little bit more commonly in the Addison's individual. Okay, osteoporosis. Who's breaking down bone? Excessively breaking down bone. The Cushing's patient, because again, cortisol is a catabolic hormone, break things down. Who is retaining excessive amounts of sodium in water, making them thus edematous and contributing to hypertension? That's the Cushing's patient, and therefore who's wasting sodium, greater risk of dehydration, greater risk of hypotension. That's the Addison's patient, okay? So Cushing's too much, Addison's too little. Here's the axis. And now let's look at different things that can cause the axis to be overstimulated, therefore putting the individual into Cushing's effect. And then let's look at things where the axis is inhibited. They're not releasing enough cortisol, therefore they are more likely to be Addison's. All right? So let's think of it. Too little. If you're destroying the hypothalamus, if you're destroying the pituitary gland, if you have hypofunctioning adrenal glands, that should make sense to you that that individual is more likely to be Addisonian, right, because they're not putting out enough cortisol. If you have a tumor which is secreting cortisol, or a tumor which is secreting ACTH, or you have adrenal glands which are hyperfunctioning, or the individual is taking in an exogenous amount of a glucocorticoid drug, that individual is more likely to be Cushing's, right? And we're going to talk about the glucocorticoid drugs. I got some slides coming up on glucocorticoid drugs, so just hang on that one for a minute. All right, move on. Cushing's syndrome, too much cortisol. Last slide showed you some different reasons why an individual can have too much cortisol. Too much glucocorticoid can be due to the individual taking a drug that's acting like cortisol, like prednisone or dexamethasone or solumedrol. They could have a cortisol secreting tumor, or they can have an ACTH secreting tumor. So in the cartoon, you can see all the different physiologic effects, and then listed as well are the different physiologic effects. This is extremely important. Just like I want you to know the physiologic effects of hyper and hypothyroidism, I want you to know the physiologic effects of Cushing's syndrome and of Addison's syndrome as well. Agitation, hypertension, edema, elevated blood sugar, muscle wasting, increased risk of peptic ulcer disease and ulcers, increased risk of infection, acne, skin thinning, bruising, increased thrush and yeast infection. In women, loss of menstruation and inability to conceive a pregnancy. And in both women and men, osteoporosis and increased risk of fractures, all characteristic findings of Cushing's. Not every individual with Cushing's syndrome manifests all the symptoms. They may only manifest a number of them, okay? So again, you kind of look at the whole picture and see if you can pick out things that look like Cushing's. You may not see everything in a Cushing's individual. Addison's, too little glucocorticoid. The adrenal glands aren't functioning. A tumor is destroying the adrenal glands, or a tumor is destroying the pituitary gland, leading to lack of ACTH. Complete opposite, right? Depression, hypotension, hypoglycemia, muscle weakness, increased risk of dehydration, low sodium, elevated potassium. The dehydration, the hypoglycemia, and the electrolyte abnormalities in Addison's disease can be life-threatening. Okay? So you see the two differences between Cushing's and Addison's. Too little, too much. And then you can take pictures again, and you can look and you can say, okay, does this look more characteristic of Cushing's, or does this look more characteristic of Addison? So let's see if you can do that with these. See if you can do that with these pictures. Take a look at the young lady on the right, right in the middle, kind of like a before and after picture, right? You see the big difference? What do you think that is? Do you think that's Addison's or Cushing's? Yeah, that's Cushing's, right? And that can happen because she's got a tumor pumping out cortisol or ACTH, or that can happen because she's taking exaggerated amounts or prolonged amounts of a cortisol-like drug like prednisone. And I know that you've all seen that. All of you in nursing have seen people on prednisone and other cortisol-like steroids, and you see them develop those cushingoid features, and you see them develop those adverse cushingoid effects such as thrush, such as increased acne, such as increased risk of infection. Don't tell me you haven't seen this. I know that you've seen this because prednisone and those drugs are so commonly used. I'm quite positive that a number of you have seen Cushing's effect from people on those drugs. So, there are a lot of different anti-inflammatory steroid drugs. Remember, if you're If the drug is an anti-inflammatory steroid, it has to be a glucocorticoid. It has to look like, act like cortisol. We have anti-inflammatory oral steroid tablets. We have anti-inflammatory IV steroids. We have anti-inflammatory topical steroids. We have anti-inflammatory inhaled steroids, right? The common denominator with all of these is that the drug is a glucocorticoid, looks like, acts like cortisol, thus giving it all that anti-inflammatory effect that we see in the endogenous hormone. Here are the systemic drugs: prednisone, hydrocortisone, dexamethasone, methylprednisone, prednisolone. They all vary in their potency, but they are all very effective anti-inflammatory drugs. And you've seen this in people suffering from autoimmune diseases. A lot of individuals on autoimmune diseases, individuals who have also post-solid organ transplant on anti-inflammatory drugs such as these, individuals suffering from other inflammatory disorders such as asthma, COPD, also on anti-inflammatory drugs such as these. Here are the 3 IV anti-inflammatory glucocorticoids: hydrocortisone, methylprednisolone, dexamethasone. You've seen all these used. You've probably seen these used in individuals who have sudden flares of an autoimmune disease such as multiple sclerosis or lupus, or individuals who have sudden exacerbations of asthma or COPD where the inflammatory response needs to be controlled. Topical steroids: I'm sure everybody at some point in their life has put a topical steroid on some type of inflammatory reaction you had on skin, contact dermatitis, eczema, insect bites, right? And again, they all vary in their potency. The common one that you see over the counter is hydrocortisone, triamcinolone, fluocinolone, desinide, probably 3 of the more commonly used prescriptive anti-inflammatory glucocorticoids. Inhaled glucocorticoids, there's a number of them. These are used, you can inhale them up your nose for people who suffer from severe allergic rhinitis, sinusitis. We'll talk a little bit about that in the pulmonary unit. Individuals who suffer from asthma and COPD, where there's a strong inflammatory component to asthma and COPD, may be able to control their asthma and COPD with daily inhalation of a inhaled glucocorticoid steroid like Pulmicort, budesonide, or Qvar, beclomethasone. Nasonex is a steroid that you inhale up your nose for sinusitis, rhinitis. Fluticasone, Flonase, another steroid you inhale up your nose for control of rhinitis, sinusitis. So lots of different ways to provide anti-inflammatory glucocorticoid effect to individuals. Systemically, oral tablets, systemically, pardon me, IV, topically on the skin, or inhaled into the lungs or up into the nose. Oh, more steroids. Put them in the eyes, put them in ears, right? You've got steroid ophthalmic products, you've got steroid ear products, and then for certain individuals who suffer from inflammation of hemorrhoids or rectal inflammation due to Crohn's disease or ulcerative colitis, different types of cortisol hydrocortisone enemas, foam enemas that an individual can have, place the steroid directly at the site of inflammation. So the nice thing about these different products is a different product can get the anti-inflammatory effect directly to the site of inflammation. And when you get it directly to the site of inflammation, it can be more effective, and it can limit the amount of steroid that you get systemically. And if you can limit the amount of steroid that goes systemically, you can minimize the individual's risk of Cushing's disease, right? So you take somebody who's inhaling Flonase, right, and they're inhaling Flonase to control allergic rhinitis, they're less likely to get Cushing's versus an individual who's taken oral prednisone, because that oral prednisone is going systemic. the oral Flonase, much less likely to get systemic. Take an individual who has ulcerative colitis, and you can manage their ulcerative colitis with a cortisol enema. You can put that cortisol directly at the site of inflammation, get less of it systemically, less risk of Cushing's syndrome. So it is really nice that we have all these different types of glucocorticoid steroid products out there. And now we have the last anterior pituitary hormone that we're going to be talking about here, and that is growth hormone. Now this axis is different. This one's a little bit weird because we're dealing with two hormones, growth hormone that comes from the anterior pituitary gland and IGF-1, insulin growth factor 1, that comes from the liver. And growth hormone and IGF-1 essentially do the same thing. They are both able to get into systemic circulation and promote growth of cells, differentiation of cells, reproduction and division of cells, and both of these hormones are anabolic. They're building things up. Where cortisol was very much a catabolic hormone, breaking down substrate for energy, growth hormone and IGF-1 are two of our primary anabolic hormones. Cortisol is a steroid. Both growth hormone and IGF-1 are proteins. Okay. The axis is a little bit different. We have two products coming out of the hypothalamus which stimulate growth hormone, and then we have one product coming out of the hypothalamus which inhibit growth hormone. I'm showing you that so that you see that the axis is a little bit different. The testable thing that I would put on an exam or a quiz is what are growth hormone, what is IGF-1, what are they responsible for doing. So I'm not too worried a whole lot in terms of the hypothalamic pituitary axis on this one. That one's a little bit weirder, so don't get too bogged down in that. But I do want you to understand the effects of growth hormone and IGF-1. Human growth hormone and IGF-1. Human growth hormone, another term for that is somatotropin. Another term for IGF-1 is somatomedin. These are both peptide hormones. You can see they're relatively large. Remember, a protein or a peptide is made up of a bunch of amino acids chained together, and then you can fold and shape that protein in a number of different ways. Each of these proteins comes from its own chromosome, so there's a gene for all of our proteins. So growth hormone has a gene, IGF has a gene, right? Interesting, growth hormone is the most abundant hormone of the anterior pituitary gland. So you can look at all these hormones that come out of the anterior pituitary gland, and growth hormone is the one there in the highest amount. Okay, so these are protein hormones. These are not steroids. And then here you can see what stimulates the release of growth hormone and what is the action of both growth hormone and IGF-1. So growth hormone, right? Growth, right? You know that this is going to be highly functional in utero, in the developing fetus. It's going to be highly functional in puberty and during growth spurts. Growth hormone, unlike cortisol, growth hormone is released during sleep, where cortisol tends to be released just prior to awakening. There's a lot of different stimuli that cause us to release growth hormone. One of the biggest factors to help us release growth hormone is exercise and nutrition. We take in nutrition, we exercise, we're releasing growth hormone. What does growth hormone and IGF do? Growth and differentiation of cartilage, bone, and muscle. Mineralizes bone. We break down fat with growth hormone and IGF-1. We produce more glucose. We go through gluconeogenesis. It's important in pancreatic function, extremely important in protein synthesis. And where cortisol is our anti-inflammatory, tamper down the immune system hormone, growth hormone and IGF-1 can actually stimulate the immune system. Remember, the immune system can be, the goal of the immune system is to repair and heal tissue. It's when the immune system gets out of control, and particularly when it becomes autoimmune, that it starts to destroy tissue. But you know that we need a functioning immune system to repair tissue. So, think of you fall, you twist your ankle, you rupture some cartilage and tendon. You're going to want some growth hormone and IGF-1 to help rebuild that cartilage, mineralize that bone, differentiate that tissue, differentiate the precursor cells back to cartilage, muscle, etc., and use your immune system to heal that tissue. And we talked a little bit about that in the bone unit, right? We talked about that growth of bone from the stem cell that you find in the growth plate that you find on the periosteum, and how that differentiates into mature cartilage and then eventually into mature bone. A lot of that is under the stimulus of growth hormone and IGF-1. So how does one hormone be responsible through so many different types of physiologic effects? It's through its effect on DNA. Remember, T3 and cortisol kind of go directly to DNA. Growth hormone and IGF, because they're big proteins, they can't get into the cell. They act on the cell membrane. They act on a receptor of the cell membrane, and then by acting on the receptor of the cell membrane, it stimulates the cell to create growth factors that go back and do the direct action on the DNA. We talked a little bit about growth and differentiation through DNA activation in Unit 1. So here's our real life examples now. Growth hormone and IGF-1 through different types of receptors, JAK-STAT receptors, tyrosine kinase receptors. Growth hormone and IGF-1 able to indirectly activate critical elements and genes on DNA to build the enzymes and the proteins necessary to induce all this physiologic effect, particularly cell growth, cell division, and cell proliferation. That's what growth hormone and IGF-1 are all about. Don't get too wrapped up in the biochemistry, but again, I think it's good for you to see this at a high level and have some understanding in terms of how this is happening. Come back to bone again, and we talked about the growth plates, the epiphyseal plate. Remember the different areas of bone: epiphysis, metaphysis, diaphysis, the articular surface, different types of cartilaginous cells found in the synovium on the articular surface versus what we find in the periosteum versus what we find in the growth plates. But those cells got to divide and reproduce and differentiate, and that's part of the function of growth hormone as well as IGF-1. So therefore, what do you think happens to an individual who's lacking growth hormone versus an individual who has excessive secretion of growth hormone, right? The person lacking growth hormone will have impaired growth of bone, muscle, and cartilaginous tissue, and the individual with excessive amount of growth hormone going to have exaggerated growth of bone, muscle, and cartilaginous tissue, right? So let's talk about lack of growth hormone secretion. Lack of growth hormone secretion is usually something that you see more in pediatric medicine. There are a number of different things that can happen genetically to an individual, a number of different types of syndromes such as Turner syndrome, Prader-Willi syndrome, pituitary dwarfism, all shown here in pictures where the individual has a lack of growth hormone. Different malformations of the pituitary gland may lead to a lack of growth hormone. And an individual who loses their pituitary gland for whatever reason, a tumor, radiation, trauma. Again, if you do something bad to the pituitary gland, you can lose growth hormone. And this becomes very problematic in pediatrics because you want kids to grow, right? You want them to become physically mature. You want them to be able to mineralize bone and grow bone and muscle and tissue. And for those kids, for whatever reasons, have lack of growth hormone secretion, they're going to manifest that in terms of their physical stature and in terms of their muscle and bone cartilage development. And again, here are 3 different types of syndromes. There's a number of different types of syndromes where this can occur. Well, fortunately, we have what's called recombinant human growth hormone, meaning that we can take human growth hormone, we can synthesize human growth hormone, and then we can inject human growth hormone into such individuals so they have a chance of physical growth and physical maturation. When we get into diabetes and talk about insulin, we'll talk more about what it means to be a recombinant human hormone, okay? Right now, I'll just introduce this concept. Recombinant human growth hormone is these individuals are getting injected with human growth hormone which has been synthesized in a lab. We are not farming humans, sucking the growth hormone out of the human and then injecting that into another human. That would make for a very interesting science fiction novel. But we don't do that in real life. We use recombinant human hormones. You'll hear more about that in Unit 5. So just hold on. For those of you that work in pediatrics, you know that a very critical part of pediatric medicine is to do growth charts at all the well-child care visits. So what's wrong with this growth chart? Take a look at this. So here we got a girl, and it looks at age, at 3 years, at age 5 years. She looks like she's doing pretty good. And then look at her stature, her height between 7 and 11 years, and you see how she falls off the chart. And then all of a sudden at age 11 years, she starts to come back up and starts attaining back to normal height. This might be something that you see in a syndrome or an individual or syndrome or other reason that the individual loses growth hormone. And what do you think happened to her to get her stature back, to catch up and get back to a normal stature again, start growing again? What do you think she was receiving? Yeah, injections of recombinant human growth hormone. Very good. All right, too much growth hormone. Having too much growth hormone, what happens to you depends on what time in your life you had too much growth hormone. If you had an excessive amount of human growth hormone before your growth plates closed, so meaning that you got exposed to all this human growth hormone, for whatever reason, usually a tumor, an adenoma secreting growth hormone is the reason this happens. If you have too much growth hormone early in life, you develop pituitary gigantism, right? This happens before your growth plates close. You grow very big in stature. You tend to grow out of proportion though. So Andre the Giant, you may know him if you were, if you're a little bit older, you may remember Andre the Giant from wrestling. You may remember Andre the Giant from the movie The Princess Bride. Robert Wadlow, I believe he was the tallest human ever. I believe he hit a height. You can look him up on the internet. There's documentaries about him. I think he got to like 8'4", maybe even higher than that. So that's excessive amount of growth hormone due to a pituitary adenoma secreting too much growth hormone early in life. Can you get an adenoma secreting excessive amount of growth hormone later in life such that you don't grow in stature anymore because your growth plates are closed, but flat bone and cartilage and internal organs start to grow excessively? Yes, and that's referred to as acromegaly. There's a very distinctive facial appearance of an individual who has acromegaly. So all this growth hormone that's being secreted in their body due to the adenoma, the tumor secreting growth hormone, they don't grow in stature, but cartilage of the hands, cartilage of the face, bones of the skull, that will all continue to grow. And from a facial standpoint, they get a very, very characteristic facial appearance. Now, I don't know, and I'm not, again, I'm not making fun of any individual here, but I look at John Kerry. You know who John Kerry is? John Kerry was he's a Democratic politician, right? I look at him and I say, boy, John Kerry looks like he's got facial features of acromegaly. Take a look at his pictures, or his photo might pop in your head, right? I think he's kind of got like a acromegaly appearance to it. Whether or not he has true excessive growth hormone, I have no idea. But I think that's what acromegaly looks like. And again, that's due to excessive growth hormone later in life, usually due to an adenoma. Growth plates have closed. You're not growing in stature. Now here's some quackery, and I'm just going to come right out, and I think that this is quackery. This is injecting recombinant human growth hormone into adults. Why do you think somebody would want to have themselves injected with human growth hormone? Now, as we age, levels of androgens, levels of estrogens, levels of growth hormone go down. We know that, right? Menopause in women, falling estrogen levels, androgen levels falling in males. Growth hormone, same thing. Growth hormone levels start to fall as we hit middle age. There's probably a reason for that. And I believe the reason that these hormones fall as we hit middle age is we are at a higher risk of cancer as we get to middle aged and beyond. And a lot of these cancers are dependent on hormones. The cells of these cancer cells can be dependent on different anabolic and stimulatory hormones such as androgens and estrogens and growth hormone. So giving middle-aged people more androgens and more estrogens and more growth hormones when they're supposed to normally physiologically be dropping it is placing them at higher risk of cancer. And this has been proven with all of these. But people are using this for a reason, right? There's, yeah, inject me up with human growth hormone because I want to get cancer. No, that's not the reason that they're choosing to be injected with human growth hormone. The reason that they're choosing to be injected with human growth hormone is they want to build, right? You're losing muscle, right? You're losing bone mineralization, takes a longer time to heal, right? And you inject yourself with this and suddenly you find out that you can build some additional bone, you can build some more muscle, your recovery may be a little bit quicker in terms of injury. So human growth hormone is considered to be like this anti-aging hormone. And middle-aged adults are now seeking this out and intentionally getting themselves injected with human growth hormone to inhibit this process, it's what's being called somatopause. Menopause, your estrogen levels are falling. Somatopause, your growth hormone levels are falling. You see this in athletic doping. What's athletic doping? Athletic doping is the use of performance-enhancing drugs to increase athletic performance, right? And you hear about this all the time in sports. You hear about this in the Olympics, professional sports, right? The Olympics, Major League Baseball, the NFL, all these sport organizations ban the use of steroid hormones like androgens, and they ban the use of human growth hormone, and they ban the use of IGF because that's considered a athletic doping or enhancing athletic performance through drugs. So that's one reason why people may inject themselves with human growth hormone. Another reason is why non-athletic individuals are choosing to do this. Is a typical middle-aged individual who, kind of like in the photo here, in the way this is being promoted, is, hey, you're going to be younger and sexier for a little bit longer because you're supplementing yourself with the human growth hormone. So has this been studied? Yes, it has been studied. And what has been shown in some of these studies is that you do, in fact, get a transient increase in muscle mass. You can see some quicker healing times in terms of injury. Remember, growth hormone promotes lipolysis, or the breakdown of fat, so you can lose some fat and you can get transient improvement in bone mineralization. The negatives of this are you can quickly develop acromegaly features, right? Because you're putting in this growth hormone, so it can act on cartilage of the hands and face and skull, and you can develop those acromegaly features. But maybe the real reason why you don't want to do this to yourselves and why you don't want to do this as a clinician is you are exposing these individuals, these middle-aged individuals, to increasing risk of cancer. Remember, cancer is all about growth, cell growth and reproduction, and growth hormone is all about cell growth and reproduction. And to think that, and that makes biologic sense, when you are at a highest risk of cancer, you want those types of hormones to be dropping. If you start supplementing it, you're going to run into problems. And there's a fair amount of literature on this to make me think that as a physician, I would not want this done to me or any of my loved ones, and I certainly am not going to participate in this type of stuff as a physician as well. Right now, the FDA only has one indication for growth hormone injection in adults. Do you know what it is? The one FDA indication, the one approved use of human growth hormone in adults is for people with AIDS, acquired immunodeficiency syndrome, who are going through wasting. So those individuals with HIV disease who are rapidly losing weight, rapidly losing muscle, who can't get weight on, FDA has shown some studies that they can reverse that process and get a little bit healthier by being injected with human growth hormone. That's the only FDA indication for humans and growth hormone. So pay attention for this. Some of you guys might be seeing this happen. Pay attention. It's out there and it's being done. Okay, enough of human growth hormone. Another thing that I would say to you is if you're really interested in the athletic doping part of human growth hormone, just do a search on Wikipedia and look for, show me athletes who have been caught using IGF-1 injections or human growth hormone injections, and you'll be surprised how many people have come up with that. Lance Armstrong, the bike rider, admitted to this. Look at pictures of Barry Bonds and tell me that Barry Bonds doesn't show acromegaly, the baseball player for the San Francisco Giants. He denied it, but boy, does he look like he's got acromegaly. I think that one of the things that Ryan Braun got busted for, Ryan Braun from the Brewers, I think it was human growth hormone. I'm not totally sure on that. You can look that up. Anyways, growth hormone, look that up. Athletes shouldn't be doing that. It's illegal. Okay. I said we were going to talk a little bit about pituitary tumors, and we are in fact going to do that. We probably got about another 20 to 30 minutes to go here, so hold on here. We're at the 2-hour point right now. Let's wrap this up with a little bit more on pituitary tumors. So pituitary tumors can come one of two ways. They can be an adenoma, which is not cancer, but it is secreting a physiologically active hormone, or a pituitary tumor can be destructive, meaning it is a cancer and it's destroying the pituitary gland and reducing the ability of the pituitary gland to release the hormone. People who have pituitary adenomas can have symptoms due to the brain tumor, headache, visual disturbances, nausea, vomiting, stuff that we're going to talk about in the neurology unit when we talk about elevated intracranial pressure. But then they also get symptoms due to the excessive amount of the hormone which is being secreted. So if a person has a TSH adenoma, what do they develop? Hyperthyroidism, right? If the person has an ACTH adenoma, what do they develop? Cushing's disease, right? If the person has a growth hormone adenoma, what do they develop? Kind of depends at what point in life. If it's early in life, they develop pituitary gigantism. Later in life, they develop acromegaly. There's also an adenoma which secretes prolactin. We're not going to talk about that. The interesting thing about the pituitary adenomas is usually the adenoma only secretes one type of tumor, one type of hormone, one type of tumor, one type of hormone. You usually don't get an adenoma secreting a bunch of hormones. It's usually just one hormone, okay? And the type of hormone which is secreted defines the physiology, the endocrine disorder that that individual is going to experience. And here on that MRI, the yellow arrow is pointing at a pituitary gland, which is like maybe 3 or 4 times the size of a normal pituitary gland. So secretory pituitary adenomas, read a little bit about them on page 722. They're not that uncommon. About 10% of the population experiences this. If you are working in neurosurgery or working in a neurosurgical ICU or working in endocrinology, you have seen people with pituitary adenomas. Again, secretion of one hormone and what they develop in terms of the physiology is based on what hormone is being secreted. They usually also will have neurologic symptoms due to the elevated pressure on the brain due to the growth of the tumor. All right, and we'll get into that when we get into neuro unit. How are they treated? They're typically treated surgically, where the adenoma is surgically removed, or the adenoma is ablated with radiation, and then once that tumor is gone, whether it's from surgery or radiation, then it's non-functional, so then the individual has to be replaced with the hormone, right? So sometimes, again, it's easier to treat the hypostate with thyroid, with the hypostate with hormone replacement. You get rid of whatever's causing the exaggerated release of the hormone, and then in time, you start to supplement them with whatever it was that you took away, right? Much less common type of tumor of the pituitary gland is a malignant tumor. This is not an adenoma. This is a cancer, which shows anaplasia, can show a high degree of invasion. So one thing that the neuroradiologist will be looking at on the MRI is this an invasive tumor? If it's an invasive tumor, it's more likely to be a cancer. And remember, invasive tumors in the pituitary gland are going to destroy the person's ability to release tumors so that they become hypo, right? They tend, if you're not releasing this tumor, then if you're not releasing the hormone, then you go into one of the hypofunctioning states. So this is one type of malignant pituitary tumor called a craniopharyngioma. There you can see it. Here you see what I remember I talked about, you trying to touch your pituitary gland by putting your finger on your hard palate behind your nose. Well, here you can see the neurosurgery team, going through the nose in an approach to the pituitary gland, and there is, what they're looking at in terms of going through the dura mater, going through the sella, and then seeing that big tumor on the pituitary gland. All right, so the pituitary tumor, the cancerous tumor of the pituitary gland can cause the neurologic symptoms of elevated intracranial pressure, but then where the adenoma is releasing one tumor, the cancerous tumor is destroying the pituitary's ability to release all of the hormones. So they develop what's referred to as panhypopituitarism, where there is a failure to secrete 2 or more different anterior or posterior pituitary hormones. So these individuals may experience hypothyroidism and Addison's and other manifestations of hypoendocrine pathology because that tumor is destroying their ability to release those hormones. So symptoms of a destructive pituitary tumor. Some of those symptoms are going to be due to the effect of the tumor on the brain, elevating intracranial pressure, and the other ones will be due to the lack of the hormone. Remember, the pituitary gland is secreting growth hormone, ACTH, TSH, antidiuretic hormone, FSH and LH as the stimulating hormones for the sex organs. So you can see now that the signs and symptoms that the individual develop are not just due to one hormone, but due to multiple hormones. So try to do this. Take a look at the symptoms here of panhypopituitarism, and can you label that to which tumor they're losing? So let's say that a male with panhypopituitarism has become impotent. What do you think that is from? Probably the androgen, right? And FSH and LH. Again, they do the reproductive hormones. A woman who can't lactate or loses her ability to menstruate or can't conceive a pregnancy. Again, that can be due to a lack of FSH or LH. Hyponatremia, hypoglycemia, dehydration, that might be due to a lack of ACTH. Feeling cold, putting on weight, that may be due to a lack of TSH and thyroid, right? So if you start to understand what the anterior pituitary tumors lead to, then you can start to understand, okay, if I take that away because of a destructive lesion on the pituitary gland, in this case we're talking about a tumor, you can then start to understand what panhypopituitarism looks like and why there's so many different symptoms that a person can manifest due to panhypopituitarism. I have posted a PDF file from the American Cancer Society on Blackboard on pituitary tumors. It's definitely worth keeping for future reference. Any exam or quiz questions that I give you on pituitary tumors is coming from this narrated PowerPoint or the readings that I post in the PowerPoint. The file from the American Cancer Society is a really, really good file. And it's just, again, it's another one of those for your information readings that you can keep in the future. Okay, moving on. So why might somebody have a total failure of the pituitary gland? A lot of different things. I talked about tumors, but there you can see a number of different pathologic events to the brain, including trauma, including stroke, congenital abnormalities where an individual may be born with an absence of the pituitary gland or partial absence of the pituitary gland. All these different things that lead to pituitary dysfunction can lead to panhypopituitarism. The individual is lacking the hormone and therefore they need to be supplemented with the end organ hormone. So people who suffer from panhypopit may require synthroid, may require growth hormone if they're a child, may require prednisone, may require sex hormone replacement with estrogens or androgens, may require replacement with fludrocortisone, a different type of mineralocorticoid hormone. And they may require supplementation with antidiuretic hormone. The drug name is called vasopressin. So vasopressin is antidiuretic hormone in the same way that synthroid is T4, right? You're talking about the generic hormone versus the trade name of the drug. So if this isn't making sense, if these last three slides on panhypopituitarism isn't making sense to you, then just sit and think about it for a while. Think of the hypothalamic pituitary axis. The pituitary is right in the middle, and if you take that out for whatever reason, a tumor, a CVA, a hemorrhage, radiation, an infection, right? If you take out the pituitary gland, you can't stimulate the end organ hormone. You can't stimulate the end organ. If you can't stimulate the end organ, you don't get the end organ hormone. So what you have to supplement on these patients is the end organ hormone. We don't give them TSH, we give them T4. We don't give them ACTH, we give them prednisone, fludrocortisone. We don't give them FSH and LH, we give them estrogen and testosterone, right? All right, think about that. Very important point. You're going to see it in clinical practice, I'm sure, a number of you, depending on what what field you're working at. I've already been seeing individuals with pan-hypopituitary syndrome. The one hormone, and this is it then, guys, we're going to be done here. The last hormone I'm going to talk about really briefly here is ADH, anti-diuretic hormone. Anti-diuretic hormone comes from the posterior pituitary gland. It's released from the posterior pituitary gland, and then it works in the kidney. We're going to get into renal later in the semester, so we'll come back and visit this. But in the kidney, anti-diuretic hormone allows us to retain water. Without anti-diuretic hormone, we start peeing out a lot of our water. That's referred to as diabetes insipidus. Diabetes mellitus is a disorder of glucose metabolism. That's our next unit. Unit 5 is all about diabetes mellitus and glucose. Diabetes insipidus is an inability to concentrate urine because you're peeing out water. And it can happen due to renal dysfunction, or it can happen due to a neurologic disorder where the pituitary gland doesn't synthesize and release ADH. So if the pituitary gland can't synthesize and release ADH, we can give the hormone back. So synthetic ADH is called desmopressin. Another term for it is DDAVP. It's very similar to the natural hormone ADH. The natural hormone ADH is a small peptide. There you can see the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 different amino acids which make up ADH. The drug desmopressin or DDAVP is synthesized ADH. And then this drug is given, it can be given IV, it can't be given oral. You take it orally, it's going to be broke apart by digestive enzymes. So you can't give it IV, but the more common way to treat people with diabetes insipidus is for them to inhale the desmopressin, do a nasal inhalation. So it comes in this kind of little pump spray that you spray it up your nose. You get the ADH systemically, and then it goes to your kidney, and then suddenly you're able to retain water and you don't have this excessive voiding. So we'll get more into that in the renal unit, but I wanted to bring this up because diabetes insipidus is another very important component of individuals with panhypopituitarism. And in addition to all those other hormones that we talked about that they get supplemented with, they also become dependent on desmopressin or DDAVP. 2 hours, 17 minutes, and 30 seconds. Not too bad. We covered a lot of material in less than 2.5 hours. Okay, so here's our last slide again. Remember that you're going to want to go through the discussion boards and post your 3 originals and reply to any of the other ones. If you have any further questions on this stuff, hit me up with an email or post it to the discussion board and see if any of our other students want to jump in and answer that for you. Now, the big difference this week is you have an exam. So the first exam, we call it Unit 1. Unit 1 exam covers weeks 1, 2, 3, 4. The general path, where we talked about cancer and inflammation, dermatology, skin, orthopedics, bone, and now endocrine pathologies. I will give you 1 extra day to get that exam done. So rather than it being done next Tuesday, you can have that extra day next Wednesday by 11 o'clock. But I will release the new content, Unit 5, I'll release that content on Monday, but I'm giving you the extra day. All right. Good luck with studying, and I'll see you on the discussion threads, and let me know if you have any questions. Goodbye.